and you follow the interincisal mandibular point, or one point on the mandibular teeth. Doesn't matter. Okay, I have the link. Thank you. Perfect. Okay, we go now. You remember that we discuss different type of subcategories of TMD. And first, we have to eliminate non-TMD patient to identify secondary TMD and to look for muscular TMD or articular TMD. Also, identify excessive bruxism, occlusal dysesthesia, and chronic myotropathic pain. It was the diagnosis part. Now we go to the therapeutic modalities. There are different types of treatment, a lot of. And the therapeutic success are globally the same, whatever the type of treatment, 75%. The conclusion for this is we have to choose a less invasive treatment. Excuse me. And there is different type of treatment. The type A is non-invasive treatment. The type B is orthopedic treatment with a splint, for example. Splint is not completely non-invasive. It's not very invasive, but it's not zero invasive. The type C is invasive treatment, structural treatment, modification of the structures, occlusal adjustment, orthodontic, prosthetic treatment, surgery, and so on. The type D is early treatment to prevent dysfunction, like regular orthodontic treatment in a young patient. Straight edge, what is it? It is a file for the to print, to assess the movement. It is. And the reparation treatment to compensate sequel, but it is another way. Okay. Non-invasive treatment. All the cases of TMD need non-invasive treatment. Some need splint. Okay, I will I will send the form by email, but I need an email address. Perhaps I have. Yes, I could send to Juliana Oheis. Type A, very large possibilities. Counseling, exercise, physiotherapy, pharmacotherapy, and some injection. In all these possibilities, I would like to underline some of them. Specifically, gymnotherapy. What is a gymnotherapy? Gymnotherapy is exercise, movement, realized by the patient himself. Soft, quiet movement to mobilize the articulation, the joint. At this moment, gymnotherapy is the best treatment for knee osteoarthritis. It is better than surgery. And the result of musculoarticular exercise reinforced with the time. When all the other therapies, all the forms of treatment, the result decrease with the time. With exercise, the results increase with the time. So gymnotherapy is a passive joint mobilization. It is a pseudo-passive because it is a movement realized by the patient himself, but without forces. Immobilization is a problem. Limitation of movement is a problem. And after immobilization, we observe limitation of movement, degeneration of the joint, muscle atrophy. For the joint, movement is life. Remember it. Movement is life. When during the movement, there are big movement of the liquid into the capsula, the synovial liquid. And it is a great contribution of the nutrition of the joint tissues. Movement is a solution for the treatment of mechanical disorders of joints in general, and specifically in TMG, because the TMG is a wonderful joint concerning movement. And this type of treatment is efficient in many cases. Frequently better than splint only. What type of movement for the jaw, for the mandible? The best movement is the lateral movement because during opening, closing, there are forces, and the patient do this movement too strong, too quick. Lateral occlusion, that is patient movement without forces. And we have alternative movement on the right side and the left side. And so the synovial pump play a very good role with translation and lateral occlusion. The counseling for the movement are 10 movements 5 times per day. 10 lateral occlusion on each side, quite, stop on the middle, another 10 times, 10 movements 5 times per day. For some patient, it is necessary and interesting to support this therapy by a physiotherapist, but just for education and observance of the treatment. When we have chronic limitation of movements, we can add gymnotherapy by stretching exercise. It was example of a non-invasive treatment. Concerning now the type B orthopedic treatment, that means splint. Why an occlusal splint? To stabilize the teeth with periodontal problem, okay. To protect the teeth from bruxism, okay. To stop bruxism, no. No. To reinforce the counseling concerning the modification of the behavior, yes. To correct the swallow, no. To balance the occlusion, in yes, with a patient with a clear unbalanced occlusion. We have retention effect to stabilize. We have a protective effect. We have a relaxing effect of muscles, but only for 4 to 8 weeks after the muscular tension is coming back. We have a psychological effect. It is a positive to reinforce the cognitive behavioral therapy concerning bruxism. I am very interested by this. And for the occlusion, only to compensate strong occlusal imbalance. There are different types of oral orthesis of oral splints. Occlusal anterior stop. We describe it. We will discuss this one and this one. I don't like too much systematic splint treatment. The splint is not teeth. It is if you put acrylic on the teeth, on a big acrylic pieces in the teeth, you change all this proprioception. And the splint induce a caricature of the function. So you cannot, from my point of view, you cannot really test the function with a splint. You can improve the muscles. You can protect sometimes the TMG or the teeth. But it is not a treatment for a long time. 1-2 months for me. We must have, after 2 months, we must have result. If you have not result after 2 months, you have to think about the diagnosis. Occlusal anterior splint is an emergency splint. You can do it with for me, the best way is to use light cure resin. The most used splint is a reconditioning splint. Generally, it is on the lower jaw for TMD case, and upper jaw for the bruxism. Always in hard resin, never in soft splint. Full arch, centric relation. Pardon, sorry, with a small anterior guidance. Indication: persistent TMD. Significant pain or strong established malocclusion. So splint is not indicated in a simple case. We have not to put the splints in all the patients with a one sign, simple sign of TMD, just counseling and physiotherapy. Two months, mainly during sleep. With contact on all the arch. We have to stabilize first, stabilize the teeth. Stabilize the teeth means we don't want migration of the teeth. And it is a risk. And it is the reason why splints are not completely non-invasive treatment. So stabilize the teeth. The teeth on the arch which support the splint and the antagonist teeth. And with a light guidance. The surfaces are flat. But we have on the anterior part a light guidance following the concept of Michigan splint. Splint must give stability and freedom of movement. The both. Stability by the contact point, freedom by the light guidance. The realization of the splint is done on the articulator. It is very difficult to adjust the splint only in mouth. It takes a very long time, and the result is not very good, not very nice. So articulator. And the step of the realization of the splint will be described during the practical days. Cast maintained in a therapeutical reference position. You add resin. You adjust the splint on the articulator. And when it is adjusted after, you can test the movement and finish and polish it. The thick, generally the thick is the same thick that you use the record of centric relation. So approximately 1 millimeter on posterior part. Another categories of splint is anti-positioning splint or repositioning splint. It depends of the terminology. I like the GELB design. The GELB design is, I have not here, I have to go back here. The GELB design is this one. It is mandibular splint with resin on posterior part, lateral part, and a metallic bar for the connection. And so the patient can wear the splint also during the day. But repositioning, for me, repositioning means anti-positioning. Almost 100% of cases are not very, repositioning are not very frequent because it is invasive treatment. And after, you cannot keep the patient for a splint during years and years. You have to have a stabilization phase. And stabilization phase means prosthetic or orthodontic. That is invasive treatment, and the decision for invasive treatment will be discussed at the end of the lecture. For this type of repositioned splint, always hard resin, where is an articulator, clearly indented occlusal surface. And for me, with anterior contact on natural teeth. I said for me because it is a concept of GELB, and I like it. Because when you maintain anterior contact here, you have proprioception for the patient. And the adaptation of the new position is clearly better. What is the evolution of the treatment of TMD from the 80s? In fact, if you follow, in 1980, it is a splint period. No, sorry, the occlusal adjustment period. We adjust all the patient or anything. I do it. I did it. Okay. Splint, not a lot at this time. And psychophysiotherapy, very, very low. In 90s, it is a splint period. Occlusal treatment is decreasing, and physiotherapy,